Morning, everyone. My name is Angela, and I'm from Canada. Welcome to our session titled Joining Forces to Meet Bladder Cancer Patient Support Needs. Today, we come together united by a common goal to enhance the support needs during and after treatment, the role of patient groups during this time, and the importance of collaboration between patient groups and healthcare professionals. Right now, we have Dr. Martin Engel with us, and he can only join us for the beginning of this discussion. So I'm actually going to pass it over to him, and then we'll come back to in the room.
Hello,
Dr. Engel,
can you listen to me?
Could you share your perspective on the current challenges bladder cancer patients face, especially in terms of support during treatment and recovery?
Okay. Thank you very much for the kind invitation to share this World Bladder Cancer Patient Forum. For me, it's a great pleasure to be there. Unfortunately, I'm not going to be able to be in Punta Cana, but I for sure I can share my opinion with this. Bladder cancer patients sometimes faces many challenges nowadays because of the toxicity the patient has to face with different kind of treatments. Side effects of the treatment, such as fatigue, pain, bladder changes in the function of the bladder. So we have to work together just to, the health system should be working together just to coordinate the approach and addressing this aspect in order to help the patient to overcome those side effects. In my institution, what we can do sometimes is work together with the urologists, the pathologists, the imagenologists, but also with psychologists that can help the patients just to deal with these side effects. We have a palliative care unit also that can help the patients to solve or how to manage the situation and how to continue on treatment, even though they have some toxicity with the treatment that we perform.
Thank you for sharing your thoughts. What role do patient education and advocacy play in improving outcomes for bladder cancer patients?
Okay, I mean, education is crucial. The patient must understand their diagnosis. What are the treatment options? What are the alternative situations that we can manage? What are the expected toxicity that we can offer to them? So the patient needs to know this information. Patient must be involved taking the decision. We have to share the information just to know what we're going to do with them. So at this point, I think advocacy has a very important role here, because they can share with other patients what they experienced and what are going to face the treatment to overcome all the complications they can have. So I think we work a lot in education with our patients. We do some seminars. We do some community advocacy. You previously heard Fiorella from Vicare Association, and also we work together with some videos, some information with some congress that we attend, all the news that we have, all the practice-changing trials that are in progress, or also those that they are negative, so they can share information what is optimal for them or not.
Thank you. Are there any questions from the audience or online before Dr. Engel disconnects from the virtual? Anyone? No? Okay, yeah, please.
I'm not hearing.
How are you, Mario Fernandez? A pleasure to see you.
So I have a question regarding, do you have a special unit exclusively for bladder cancer patients? I mean, not just genitourinary, instead bladder cancer. Anything special for them?
Not at all. We have a GU oncology unit. So we do kidney, bladder, prostate cancer, all the GU tumor involved in this field. But we manage with all the colleagues, the urologists, pathologists, radiotherapists. So we manage all together.
Okay. And regarding the information you give to the patients, do you have a special professional over there that gives information to them regarding, nursing staff, psychologist, or something like that?
You mean like a nurse practitioner or something like that?
Yes.
No, we do not have that one in Argentina. The patients, the oncologists do sometimes the information, but also when the patient goes to the infusion room, we have some nurses specialized just to tell the information about that treatment. Regarding the other psychological effects or some other how to manage, we work together with the palliativist care unit. So we have a clinician, we have also a therapeutic, psychological therapeutic that can share with them, and they can work in some groups also.
In our hospital, we experienced a very significant change when we included a nurse exclusively to give information to the patients, not for bladder cancer, but also for all of the urological cancers. But I mean, when the patients get out of my room, he goes or she goes to this nurse, and she immediately gives him a lot of information. So the patients, for example, if he gets the diagnosis, part of the workup of this diagnosis, I think, is very important to immediately have a lot of information to see what will happen after that. And I think a nurse in that case is, at least for us, has been very, very significant.
I agree with that, because doctors are always on a rush, always trying to be in many parts at the same time, and we don't have the enough time to share the information with the patient. I think it's very crucial to have these kind of nurses that can help to do it.
That's exactly the problem. We discussed it before, that we are always in a rush. Yeah.
Mm-hmm.
They just gave me my own one. No, I'm joking. One of the things, hi, I'm Lauren from South Africa. I run a patient advocacy group. One of the things that we're seeing in a lot of low to middle income countries is, we're seeing a push to navigation. I worry, though, that in countries like ours, we are pushing towards nurse navigators, where we already have a shortage. So those nurses are responsible for doing the actual treatment, making sure that the clinical side of things. And I wonder if we should not be focusing to make sure that we're properly training lay navigators, because in each one of our countries, we already have a shortage of nurses. In South Africa, we don't have specific oncology nurses trained. There's probably a handful. So I'm thinking of that, and I'm thinking, how can we look together to say, how do we start promoting the idea of properly trained, certified lay navigators that can help those patients in that? Because I think we're going to run out of professional nurses, and the nurses are helping you with a lot of the clinical stuff that you have to do.
May I
Navigators, that's such a good term. Yes.
Can I say something about navigators? Here in Argentina, at least, navigators are useful for helping the patients just to get access to medication, how to solve the administrative or the bureaucracy that we have with the third payers or with the insurance, but they are not able to respond to some side effects or toxicities or how to face the treatment. So navigators are very useful, but in another situation here in a lower income country.
So Actually, our nurse has the name enfermera de enlace, which means the link nurse, you know? She links the patients with everything he has to do, including information. So for us, it has really been a great change.
Yeah, any other questions? No? Well, thank you, Dr. Martin Engel. We're glad that you were able to join us. And I hope you have a great rest of your day.
Thank you very much. I'm so sorry I have to disconnect.
Yeah.
Bye-bye. Have
Thank
a
you.
nice day.
Bye-bye. I just want to share a little bit of my story. Like many, I never imagined cancer would become a part of my story. The diagnosis was shocking. The path felt very uncertain. But as I navigated the difficult road, I discovered incredible support systems that helped me not only survive, but grow stronger. Today, I want to talk about some of those resources that made a difference for me. My life took an unexpected turn 5 years ago. It all started when I noticed blood clots in my urine. At first, I was treated for a urinary tract infection, but the blood clots and the pain in my bladder and my back didn't go away. That's when my physician sent me for a cystoscopy. And in November 2019, I heard the words that would change everything. You have bladder cancer. So I started with treatments. I began BCG treatments, and underwent 4 TURBTs. And that was all throughout a year. Every time I held on to hope that the treatment would work, that the surgeries would get rid of the tumors for good. But unfortunately, BCG didn't work for me, as it doesn't for some. And every surgery, the tumors came back. The hardest moment was when my doctor told me that my last tumor now showed it was muscle invasive. That news shifted everything. My treatment plan changed completely, and I started 12 weeks of chemotherapy, followed by a radical cystectomy. After my bladder removal surgery, adjusting to the physical changes was tough. Learning to care for my new urostomy felt overwhelming. I wasn't just recovering, I was adapting to an entirely new way of living. Finding the right appliance, and even simple things like finding clothes that fit me comfortably around my pouch, all became emotional challenges. I often found myself in tears, feeling frustrated and overwhelmed by this new reality. Then one day, my doctor said something that changed my perspective. He reminded me that my urostomy pouch was there because I didn't want to die from bladder cancer. That thought shifted my mindset from frustration to problem solving. I began experimenting with different solutions, and through trial and error, things got easier. With each day, I gained a little bit more confidence. Early in my journey, I discovered Bladder Cancer Canada. It was during one of my late night internet searches. I had so many questions about treatment, surgery, and what to expect. And BCC quickly became an incredible resource for me. I found myself watching webinars, reading through their guidebooks, even those that didn't apply to me at the time, because I wanted to be prepared for anything. When my cancer became muscle invasive, I already knew what to expect. And thanks to BCC's resources, I felt empowered rather than lost. Educational resources like guidebooks were essential in helping me navigate the medical world, which can be very overwhelming. These guidebooks provided me with up-to-date information, from treatment options to what to expect during recovery. Having the knowledge gave me the confidence to ask questions and advocate for the care that I needed. When so much feels out of your control, information becomes a very powerful source of strength. As women, bladder cancer can look very different for us compared to men. One of the biggest challenges we face is a delay in diagnosis, as our symptoms are often mistaken for something as common as a UTI, just as it was in my case. This misdiagnosis can lead to delays in treatment, which unfortunately results in poorer outcomes and the needs for more aggressive treatments. For women undergoing a radical cystectomy, the surgery may involve the removal of the reproductive system, adding another layer of emotional and physical challenges involving hormonal imbalances. It affects body image, it impacts sexual health. The introduction of an ostomy pouch can further affect self-confidence, especially when it comes to intimacy. This may make women feel isolated due to the lack of awareness and the societal pressures around appearance. Historically, bladder cancer has been seen as a man's disease, but more women, including younger women, are now being diagnosed. This shift calls for better treatment protocols, that address the unique physical and emotional challenges women face. Beyond medical treatment, emotional and community support play a crucial role in healing, and that's where peer support groups come invaluable. I truly believe that joining a peer support group can make all the difference. I'm a part of a women's only group, and it has been an incredibly empowering experience. Being with women who understand the unique challenges we face, it creates deep connections, shared understanding, and open conversations. It's a safe, supportive space where I found not only advice and encouragement, but also strength. Knowing I'm surrounded by people who truly get what I'm going through. For anyone newly diagnosed, the emotions can be overwhelming. There's fear, confusion, there's isolation all at once. Listening to others share their experiences helps ease that isolation, and you quickly realize there is life and hope beyond the diagnosis. While peer support groups provide a sense of community, another great resource is peer one-on-one support. Whether it's through a phone call, email, or video chat, having a dedicated person to talk to, especially someone who has been through similar experiences, provides a safe space to address specific concerns, whether it's advice on navigating the healthcare system, coping with emotional stress, or understanding treatment options. And it's not always about the big things. Sometimes it's small, practical advice, like how to manage side effects, or what are some tips on just staying positive. This kind of individual support is invaluable because it can provide guidance when you need it most. Looking back on my journey, I can honestly say that these forms of support were and continue to be critical to my well-being. Bladder cancer is a challenging diagnosis, but I've learned that none of us have to walk this path alone. I'm grateful for the support I've received and the lessons I've learned, and I encourage anyone facing this journey to reach out to access these types of resources. Whether it's finding a peer group to lean on, connecting with a survivor one-on-one, or simply educating yourself through guidebooks or webinars, there are tools available to help you every step of the way. Thank you for giving me the opportunity to share my story. I'd like to pass it over to Melanie now. Melanie, what kind of support do you think is important for a patient who has just been diagnosed? Give you a chance to actually, why don't you let the group know who you are and
Right, here we go, start again. Right, so hi everybody, I'm Melanie Costin. I'm the Director of Patient Engagement and Support at Fight Bladder Cancer in the UK. And I'm also a bladder cancer patient myself. I'm high risk and they've upgraded to very high risk now, which that wasn't around when I was first diagnosed. I'm doing really well. I had a little blip this year, but bladder cancer likes to keep us on our toes. Yes. So when I was first diagnosed and I saw the nurse for like literally 5 minutes, I was told that they weren't going to try and cure me, but they would try and treat me, and goodbye. And so I walked out slightly panicky, and I did notice this book about bladder cancer. It was in a stand. It was very old-fashioned. The stand is so we have somebody called Macmillan. They're a really good service in some respects, but they rent all the stands in the hospital. So their information was all that I could get. And I saw this book, and it was the size of War and Peace. And I opened it, and honestly, it was harder to get through than War and Peace. I have actually got through War and Peace. And so the first page said, okay, everything's going to be great. Loads and loads and loads and loads and loads of writing. And the last page was, things are not going to be that great. And I literally, in the mood I was in, I just got it and I tossed it through the air. I've never seen it. I don't know where it is. I think it's in that hole where all the socks disappear. But I didn't care to ever look at it again. It's really, really important to have accessible information right from the very start, so that you don't go looking online, because that can be rather destructive, and it's not always helpful. There's lots of nice information on there, but you generally don't find that when you're in a panic state. So we decided, in a moment of madness and wisdom, that we would create our own information booklets. I did have some slides, but I'm going to oh, I have still got some slides. I couldn't really bring everything to show you, so I thought it might be easier just to have a picture. And so we designed some booklets which are to provide clear and accurate information. It's very patient friendly. It goes through the whole stages of the bladder cancer journey. So if you are concerned that you might have bladder cancer, then it's okay. There's no slides. I'll just wing it then. So my beautiful slides would show all of these booklets. So if you suspect you have bladder cancer, you can contact us, or get hold of this information, and you can look up the tests and investigations, and you can find out what that consists of, because they're not very nice tests and investigations. Oh, there we go. That's a sample of some of our booklets. They go through the whole range. So we've covered non-muscle invasive, or the different types, low grades, high grades. We've got living with a stoma, living with a neobladder. But it's very important to continue on with that information. When you've got more of a brain to think about things, you might want to know a bit more about how you can live well. So we've included that. We're in the middle of doing some new booklets at the moment. So we have the newer treatments, which are types of immunotherapies and targeted therapies and things. We've got a fantastic book for carers, because it is really important. I can see some carers here today, and it's really important that they also understand about the journey and how they can help, but also, how they can help themselves to get through everything. And so we developed these in collaboration with professionals, but more importantly is that the patient voice is actually at the front of this. So in our booklets, we have pictures of real people. Oh, maybe there's another slide for people to see. So I just wanted to point out that I know that's actually a really nice diagram, I think, but it shows that men and women get bladder cancer, because everything was about men, and I'm not a man, as you can see, so I wanted to know about women, and I couldn't find any. But we have these really okay, they're very clear, but I think they're nicely done. And if you'd like to show the next slide, please. So this is just a sample of the fact that we use real people. We actually use people that we know, that are willing to help, and we have a huge amount of tips and tricks, things that people have gone through that they can suggest. We know all of these people here, and they very kindly have sent us pictures. We have pictures in the magazine. You won't be able to see it from there, but we have what real stomas look like. So all different. And we have people getting on with their lives and actually managing to live well with after a diagnosis of bladder cancer. So these booklets at the moment, you can access them lots of ways. You can get them through your healthcare professionals, in the fact that we've made lots of contacts with the clinical nurses now, and so they can order them for their patients, or they can suggest them, but they get a larger version in a big file, and it's quite helpful for them to discuss things and show people what they might be going through in a nicer fashion. So you can also, it's important to remember really that bladder cancer does still affect a lot of older men. And I don't want to generalize, but some people haven't really got to grips with the computer, and they don't really want to start learning when they're ill. So you have to provide information that's accessible to everybody, whether that's an online version or something that you can post. We post all our information out as well. So it's really important to remember that. So yes, that's our patient information booklets. It's not an easy thing to start, but it's really, really worthwhile. And I really wish that there was something like this for me. This is quite a thin one. They're all different sizes, obviously, depending on what your diagnosis is. But we've really tried to cover everything and really bridge that gap of care that was hugely missing when I picked up War and Peace. Thank you.
Thank you, Melanie. That's great. Thank you. I want to, well, you've been introduced to Dr. Mario Fernandez earlier today, but would you like to share your thoughts?
Yeah, so I'm so glad that I'm with two women patients here. We were talking in the little group about bladder cancer in women. So I think there are two special things. The first one is that, recurrent urinary tract infections is a very common condition in women, especially after the menopause. So it is very common for GPs and also urologists to see women with hematuria and maybe some urinary bothers, give them antibiotics, maybe do some urine tests, maybe. But the reality is that we have a lot of women. I just was telling that 2 months ago, I diagnosed a woman with a metastatic bladder cancer after 1 year receiving like 6 antibiotic trials, you know. So it's very important to get awareness for women, because the story is different for men. So that's a very important point. We always try to teach this to our students and residents, but I think it starts with the population and then with the GPs. It's very important.
Yes, I agree.
So-
In a women's group that I'm a part of, I can say any given night, if there's new members, old members, how many people here raise your hand if you were treated for a UTI before they found your cancer? And all hands will go up in the room.
Yes, 100%.
Yeah.
Yes, because the reality, for example, in Chile, the GP in Chile, he does not or she does not order urine tests. The patients simply get antibiotics and goodbye, you know.
Right.
And if it persists, come again. And if she comes again, another infection and then antibiotic again. So it's really a big issue.
So what happens for a physician? When do they decide, okay, maybe it's more than a UTI? When do that change to, we need to start investigating something different?
So if you have really blood and urine clots, you have to get studied, especially if you have risk factors. If you are a smoker or a former smoker, this is very important. Former smoker is just as important as active smoker. Or you were exposed to any other risk factor, but the most common is smoking. And especially if you do urine tests and the culture is negative, so you have to look for something else. The problem is that you have to get a cystoscopy in those patients, and this is probably the problem, because for a cystoscopy you need a urologist, you need a room, and it's expensive, and there's a waiting list. And so there's a lot of investigation going on, a lot of research going on, looking for markers that can help us to select patients that can skip a cystoscopy, for example, but we are not there yet. We have to,
Right.
there are no approved agents that can help us on, so we have to further look for it.
Right. So there's not a lot of proactive tests right
No,
now.
no. The problem is that if you study the patients, you have to go to a cystoscopy. There is some, depends on where you work. Maybe there are some centers where the ultrasound is well done, but that's not the usual condition. You know, you have to have a very good ultrasound specialist, but even so, you can miss a flat tumor carcinoma in situ. So the problem is this.
Thank you.
And the other thing with women is all of the sexual function, because that's also a topic, an issue that urologists often gets overlooked. So the doctor doesn't talk to the women about that topic when they get a radical cystectomy, for example. So it's also a very important issue that has to be taught among residents, urology residents, and also practitioners.
Well, in my case, I had my radical cystectomy 3 years ago. My doctor was just, we're going to remove everything, your uterus, your fallopian tubes, everything comes out, because that's usually how it is. But I've now been learning from other women that there are nerve sparing, there's organ sparing, there's different things. But even 3 years ago for me, it's not something that my urologist spoke to me about. So I think
that's very relevant and important, and that's the work we urologists have to do. Maybe Dr. Polo has to say something about that, but
yeah. Is there
it's
any
very
in the
important.
audience actually would like to have a question or want to speak?
Well, in my talk, I will talk about
That's great.
the improvements in urology, but also the things that urologists have to improve.
Great.
Okay. And this is one of them. Quite often, cystectomy in general means bladder out and back. And this is not true. We can do a neobladder, we can preserve the nerves, have sexual function, have incontinent. So, so specific centers with training, with a lot of cases, these are the ones that have to do cystectomy. The center that do 3 cystectomies a year is not a good center. So, and I think in UK, I think this is quite done in now in kidney cancer, in bladder cancer, in penile cancer. There are centers of referral, and then they get a lot of experience and they do a better job. So I think these are also things that the society, and the governments have to improve throughout the countries.
Well, I look forward to hearing your presentation.
Mm.
Anyone in the room? Anyone online that's looking to ask a question? No? Oh,
Yeah, I have a question for Melanie. You mentioned that you have patients that are contributing to writing your pamphlets. Do you also get doctors and nurses involved in that process?
Yes.
How does that work? Just in a really short time?
Yes. So it's actually a really long process for anybody that's thinking about doing this. And I hope you are. You've got to make sure that you've got plenty of time. And you don't start in the pandemic thinking all of the professionals are going to have plenty of time to spare like we did, because we were very wrong there. So obviously the patient voice is at the fore, and that's everything in Fight Bladder Cancer anyway. But everything has to be thoroughly checked. So you start off with your draft of what you want to say, and you build it up in the normal way of writing something. But you have to have, it has to be so thoroughly checked all the way through. We have lots of medical professionals that we work with. We've every stage of the booklet they was involved. When the booklets are almost in completion, we send them out. We send them out to a whole range of people. So this is CNS nurses, and that's the name for our clinical nurse specialists. And we've made some really good relationships with them and with surgeons. So there was a lot of people who were quite keen to get involved with this because it was something new. But keeping on track of the information is really important, and you have to keep in contact with the professionals as well, because you know there could be some changes, there could be information that needs to be adapted. But obviously the patient voice being at the fore, but you can't do it without professional help, because there's just too much to do a whole bladder cancer journey and everything that's involved just through patients. So yeah, you do.
Melanie, what do you think the importance of the peer support groups are?
Peer support, so really, really important, I think. I try and tell people to join. So for example, we have a forum. It has over 6,000 people on it. And this is also medically backed as well. So we have professors in neurology who's on there, and other specialists dip in and out. But the thing is, it's knowledge is power, and speaking to other people is really important. So for me, all I wanted was to see somebody else that was similar to me, really. And in my mind, if I saw somebody like that, then if they can do it, then maybe I can. But also, you haven't got the time with the surgeon realistically, or even with the nurse, to ask all of those day-to-day questions when things go completely wrong. And you know, peer support groups really do bridge that gap, because they can provide information, they can provide patients to speak to that have already been through the procedures. It's not about telling people what to do, it's about explaining how it was for them. And that's the only way you're going to hear about life and about these things, is if you speak to someone who's already been through it. So for me, it was crucial. It's the only way I got support for a very long time, was talking to other people that had got bladder cancer, whether they had my type or not. I just felt like I wasn't out there on my own, and I was a woman as well. I would go into a hospital, and I still do this. There's lots of prostate men in there, and they look at me like, what is she doing here? You know, and I'm like, hi, everyone. Just in for my prostate check. So, and actually my surgeon, he's so pleased to see me. And it's, hello, everybody else gets a Mr. So-and-so or whatever, but I get, hi, Melanie. And, you know, the fact that they're seeing me they like that because it's something, it's new, it's something new, but actually it's not unusual. It's
No.
just in my area, it was very unusual.
Right.
But
And
clearly
it
isn't.
It is unusual, but
Well-
we are seeing it more and more. I have I think there's 89 women in my support group now, and
It's what is it? It's the 11th. Is it the 11th most common in women in the Western world now? It's always changing. That's huge.
yeah,
Like that's not uncommon.
no,
And
no, that's
and a
true.
lot of people don't follow any of the high risk things. So there's a lot of guilt involved that some maybe women have done something to themselves to make this happen, and they haven't smoked. I mean, we've got a lot of information now on secondhand smoke and vapes,
Right.
that secondhand smoke and smoking, the same sort of chemicals. So, and who hasn't secondhand smoked?
That's right. Yeah.
You know, so.
I agree with the importance of the peer support groups. I know some of our ladies, we give them some information so that they can go to their doctor and like, oh, I have these questions.
Yeah.
And they may not have thought of that themselves or ahead of time and wouldn't have had those answers to come into the office with.
Exactly. And I mean, we support people from all over the world. So if there's anybody and you don't have a support group in your area, I mean, I think everyone's covered here. But I mean, we have people from Hungary, and obviously the language is hugely different, but we've got Google Translate is fun and games, but it's still better than, you know, this poor lady in Hungary with nothing. And they see other people as well, and it's really encouraging. So we have people in South Africa, America, absolutely everywhere, because I don't know whether the UK has a certain way of talking about things. You know, we just say it and laugh when it's bad. And some people like that. So, you know, there are support groups all around the world. And if something doesn't suit you, there's others there. And it's great to see that now. It really is. So
I think we have a question from the audience. Oh, you, Michelle.
Hi, it's just Michelle. Actually, going on what you were saying is I think one thing we can do is to share resources in other languages. We in Canada, we've now got not only English and French, but we also have our material in Spanish, Cantonese, Punjabi, and Hindi. And we've been getting a lot of requests for Arabic language as well. And I think that's something, if we don't have a startup guide per se at BCC, but we've got a lot of material on if you're diagnosed with a bladder cancer diagnosis or your treatment along the way. And I think that's somewhere where we can partner with Dr. Fernandez and Dr. Palau and say, we've got material in Spanish or any other language. And I think if we find gaps, like Melanie, you were saying in Hungarian, maybe that's something we can find funding and joint funding together. Because I think that's often forgotten, is your language is English for us in North America, when that's not the demographics anymore. So I feel like we leave a lot of languages, and a lot in that sense, patients, we leave them out.
yes, thank you, Michelle. Exactly right. And we have started to translate, and actually we got some help from Michelle. So, you know, a lot of the work's been done already. Why not take some of the weight off your shoulders and ask the ones that have already got grey hair from doing it?
I'm Amy as a patient. I relate to what we're talking about regarding the language barrier, because I myself was from Senegal, and there's now resources and nobody to talk about it. They all found out about bladder cancer from myself. So I had to write it in Wolof, which is the African native language, for certain people to understand. And the primary language is French. And if I didn't, I've been following this coalition who helped me so much for the past 2 years. And that's how I get in touch with bladder cancer in France to see what they do in French in order for me to bring it to my page for my people to understand, even though I speak French, but I am more Americanized because I lived in America. So I cannot express myself in the terminology. I use the one from bladder cancer in France to put it in my post for Senegalese to see it. And it helped them a lot. Also, I have one more question for Dr. Mario. As a patient, I still don't understand how I got bladder cancer. I don't smoke. Well, I know passive it could be. I've never been involved with any toxic. So as it is a question for my people in Senegal contacted me to ask me how did you get it? I cannot answer that.
Well, we have a group of patients where we don't have a clue, actually.
Okay.
So there is a genetic basis, which is not that important for bladder cancer, as in, for example, kidney cancer. And I would say that most of the patients we don't know are probably secondhand smokers. So they were exposed when they were little at home, maybe. Or I remember when I'm 48, when I was a kid, everyone smoked in my presence. So that's probably the factor in those cases. In Africa, was your cancer urothelial, not a squamous cell? Because of the schistosomiasis, it's a parasite that you have in Africa.
But I didn't live all my life in Africa. I was
Not in
in
Senegal.
America.
Okay.
I was in America.
Okay, I see.
So, and I only know, I found that because
Yeah.
I had constipation and I went to see the gastroenterologist, and that's how they found out.
So it's probably secondhand.
So, secondhand smoking, I can relate to that because my ex-husband used to smoke. And that's why actually on my own language,
that's probably enough.
Yeah. That's why also on my own language, I wrote in my slides that because in Senegal, we use a lot of incense, burning incense with the fire inside the room and everything is closed.
Maybe.
So I thought that also could bring, even though it's toxic. So I wrote it and I tell them to stop doing that. I know I love burning candles. I stopped that. So just to ask if it's the part of why I got bladder cancer.
I think it's not a established risk factor as far as I know, but maybe we don't know.
Okay.
So maybe.
All right. Thank you.
Would an established risk factor be, a lot of women have UTIs and it's common. So the inflammation, is that?
Yes, it's also in some, but not for the urothelial cancer, it's more for the squamous cell cancer, also chronic inflammation. So, but it's really a rare, I would say that I think it's probably also smoking, but you didn't know that.
Okay, because I noticed in my group when we asked that question as well, and many say, no, I'm non-smoker here. But
probably secondhand.
That secondhand, and
It's probably, yes.
But there's so many more things, isn't there?
But I wanted to say that.
Yeah, just
Please,
to mention, second-hand smoker, you mean passive smoker?
Yeah.
Oh,
Yes.
okay.
Right.
Okay, not just to know it.
Yeah.
Okay. No, it happens quite often. I mean, it happens quite often that, as it was said, when I was 30, I was 40, I was in an emergency room, the doctors were smoking there. It was at the university, people were smoking in the class. And so, I was a passive smoker for a few years, even I was fighting really hard at that time against it. So, and also we talk about to talk patient to patient. I think this is very important. Myself, I have a list of patients that had cystectomy, nephrectomy, TURs, multiple treatments, that they are my selected patients, let's say, or the patients that accept to be called. So when a patient has a doubt and so on, say, okay, I have 2 or 3 patients that can talk to you, say, and they call them, and then they meet or they have a coffee and they explain all the experience and so on. I think this is very important to create a kind of, maybe this the patient coalition have to send a message to the urologist, have a list of patients in order your patients to talk to. I think this could be also very easy. Does not depend just to have a global organization of patients ready to talk, but each urologist to have a list of patients in order to talk to.
I
The
agree.
next
That would
patient.
be an amazing.
Maybe to promote this concept could be good all over the world.
Yeah.
Yeah, go ahead.
I was just going to say something as well, that a majority of people can never know how they got bladder cancer, but there's no blame, even if you've done something wrong. It doesn't matter about that. It's what you do from it, what you do about it from now. But it's not just smoking, Amy. And I don't mind talking to you about it afterwards when we've got some time. But we've been doing a lot of work on the workplace hazards, the risks. There's so many different things that we now know can give you bladder cancer. Certain dyes, certain chemicals, certain pesticides, the fishermen with their maggots covered in chemicals, the dye, and fishermen were getting it and we didn't know why. There's so many different ways you can get it, but I really think that once you have it, that's, you know, it's what you do about it now, and there's no blame really, is there? It's just one of those things.
Absolutely, absolutely. But we have to, if the patient still smokes, he has to stop.
Yes.
Because it's so important.
Yes.
It has been shown that patients that keep on smoking will do worse than those who quit.
Yeah, I think you make a good point. I'm going to jump to the audience for questions, but I think you make it a good point is to not try and blame yourself, because we all do search inside ourselves. And I thought, gosh, I used to color my hair all the time, or I stood around a bonfire, like, and you're not helping yourself, you know, physically, mentally, to kind of dig to see why you got it. So it's better to just look forward and how to.
The problem with that is that it will be, you won't able to avoid it because the doctor will tell you. You will ask, why is that? Because you smoke or you smoked.
That's right.
So I think you will have to get through this anyway. But I think it's a good way to not to blame you, but someone has to tell you. You won't find alone. So that's why important to speak with other patients.
Sure. Thank you. Michelle?
Thank you. Just a question for Dr. Palau, actually related to what you were saying, that the urologists need to speak to patients more directly, and then have that resource if someone's diagnosed with muscle invasive, that someone else has gone through it, that peer-to-peer connection. That's one of the gaps, I think, and something we need to be doing better is encouraging urologists to have that conversation. I appreciate that, you know, everyone's busy, that you have a few minutes maybe with patients, but even something that you can give them, something so that they feel like, oh, okay, you're listening. Because when you get the cancer diagnosis, you don't hear anything else. Patients tell me all the time, I hear cancer, I hear nothing else after that. So it's spending that time with the individual and then making sure they have a peer with whom they can connect, but also, with all due respect, reminding your peers to do the same. It's, you guys are awesome. Yeah. But in Canada, we're not always awesome there.
I will talk to my friends.
Please do. Please.
I will make a call tonight. You know, the thing, I think it's not easy, but for example, a center dedicated to bladder cancer, maybe muscle invasive or metastatic bladder cancer, has to have first a multidisciplinary approach. And then, for example, in cystectomy, to have the ARES protocol. So all our patients, when we diagnose a muscle invasive or go for radical surgery, we have our psychologists. So they join several patients and will have radical surgery, and they talk to them and see, and you very, how do you say, subtly, no? They detect which patients have very good knowledge of the disease, tranquil, accept the disease, very good family support, and those, okay, they are doing well. But if they detect one or two patients that are not under control mentally, let's say, then they talk to them more specifically and personally. I think this is one important step. And the other one, having the ARES protocol, the patients visit the nurse, the stomatherapist, they show all the graphs, the diagrams, and so on, explain the possibilities and so on. Then they talk to our anesthesiologist, that also explains the dangers of the surgery and everything. So finally, when they will have to do some exercises, breathing exercises, walking exercises, and so on. So that really, when they get to the surgery, they are pretty conscious of everything. They know about the majority of things. So I think this is an important step to be established in every center that we suspect. Otherwise, it's not the best way, because then they are more able to handle this difficult path for their lives, which is just even we are very good surgeons, of course, but still for the patients, wow, it's an amazing change. So I think these are all the steps are really, really important, and even more. So if we have several patients that already have undergone this surgery to contact them, then it's really.
And I think you should never use the word cancer with a patient if you see him the first time. we should talk about palliative disease or even tumor. But if we use the word cancer, search is included in all of our trials. So as far as this time now, there are not special issues about different drugs having a different action in women or men, but we're aware of them. But as treating decisions, we have to be better with women and care about this, their specific cares and fears.
Very more question from all participants. And just before I say that as well, Melanie, you've mentioned additional risk factors. And so this question talks about there are many subtle factors in Africa, like smoke emitted from firewood used for cooking or smoke emitted from kerosene cooking stoves. So the question is, could public health officers and environmentalists look into them? Obviously, we don't have them in the room, but I think it's an important question is for us, as opposed to have a look into existing research into these areas and then follow up on that. But if you have any comments to share on
Well, yeah, I mean, I do have comments, really. It's so difficult because you need to know, it's not so much whether there's a bit of smoke going through the air and where it's come from, it's what chemicals it contains. So, you know, I've actually thought that about joss sticks, for example. We were just talking about incense. I absolutely love them. And I was just sitting there thinking, okay, but is there any research looking into chemicals and things? So I do think that we know that now that certain pesticides that we use in the UK that used to regularly crop spray over the fields right near my house, we now know that has a chemical in it that is a high risk of bladder cancer. And the only way that we can find out is if people look into these things. So yes, there's the smoking. Now I've got the new thing, which is my pet hate, which is vapes. And I was thinking, what is it about the vapes? But it's the chemical that's for the smell, to make that the smell of it. And the problem we have in the UK is that children at school are having vapes. So it's not a step from getting off smoking. It's very trendy and fashionable. They flash, they've got lights and all that. And all of the chemicals that are used in industries, machine oils and so on, we know that some of those chemicals are dangerous. So I don't know what happens in that country, but obviously it has to be looked into. Otherwise, how do we know? If you don't have the knowledge, you can't do anything about it.
what I said in my talk early morning about the underrepresentation of the third world in cancer research. So there are probably a lot of factors. So bladder is among solid tumors, it's extremely dependent on environmental factors. So we have the arsenic story in some countries, and there are probably more stories, but we have to. Someone has to look for it.
As I said before, I am new in this field. In the Dominican Republic, we don't speak much about bladder cancer. In listening that more than 75% of people suffering from bladder cancer is due to the vapor. Here we see electronic cigarettes, the vaping, hookah. So I want to know if it's only the tobacco cigarette per se, or is it rather everything inhaled? If there's a specific chemical that causes this cancer and something else that I haven't heard, probably because I was not wearing my headphones. What are the symptoms, aside from bleeding, that can determine that you could be a patient suffering from bladder cancer? I have many unknowns and questions not solved, but light will be shed, I'm sure.
So Maria was asking about okay. She was asking about is it the tobacco, the carcinogenic compound of the cigarettes, or any other chemical? And the second question was about the symptoms. I can respond about the symptoms of cancer. So hematuria, blood in the urine is 80% or more of that. So beyond that, urinary symptoms like urgency, frequency, dysuria, which is burning during the menstruation, that's more often the case in women and people that get some flat kind of tumor, the carcinoma in situ, but it's less than 20%. And beyond that, very rare you will have some systemic symptoms if the cancer is metastatic, pain, bone pain, or abdominal pain, something like that. But it's hematuria. It's usually hematuria. That's the symptom.
And frequency, I would think.
Yes, frequency, yes. All of the irritative urinary symptoms, frequency, burning, and urgency, but it's less common, but proportionally more common in women. So in women, you have to always, as we talked about the UTIs, the urinary infections, you always have to be sure that it was a urinary infection and not something else.
But it's not always an urgency. Have you got your? It's not. It's not always about the urgency. It's about not being able to physically go to the toilet when you get there. You just can't.
Okay,
Only small amounts. And so over time, this creates a lot of symptoms. Weight loss, for example. It took me almost 4 years to get diagnosed, because also for women, mental health. So we get sent down the mental health route in the UK, because there must be something wrong with our brains sending a message to the bladder. But it's like really needing to go to the toilet. But when you get there, you just can't go, just a tiny little bit. And it's horrible. And a UTI it makes you hallucinate as well and confused. So a lot of elderly people are getting diagnosed with beginnings of like dementia, because they're displaying similar signs. So, and this was what I didn't get diagnosed with dementia, but sometimes I didn't really know what was real and what wasn't. So there's a lot of symptoms. There are a lot. But you know that the common symptoms is you know yourself, and you know when things are different when you go to the toilet. And blood, if you see blood when you go to the toilet, then get it checked, no matter what. It will probably be nothing, but get it checked.
Thank you, Melanie. It is
Question was about the toxic compound. It's tobacco. The tobacco is the toxic compound of the cigarettes, and there's a lot of pathways, methylation pathways that are activated or deactivated with tobacco. So it's tobacco the problem.
okay. So it's not just it's the tobacco.
Well, it's all of the processes, yes, but
right. It's it. And I see.
In the urine into the bladder for several hours, these chemicals interact with the bladder wall. And this takes years, 10, 15, 20 years. But are the chemicals that are in the tobacco? Sorry?
Thank you.
Every tobacco is bad.
We're headed
Oh.
into lunch now.
Some of them are even worse, but all of them are bad. So
Just going to take one question. It's all over here.
Comment.
Okay.
Just, it's something we hear every day in our bladder cancer patient support group in France. Those 50% of people that didn't smoke don't know why they have bladder cancer. And it's something I've thought about a lot because not knowing how you got it, I think there's the underlying feeling of, not having control over doing something to not have it recur, because patients know that recurrence is frequent. And those patients who were not smokers and are not currently exposed to passive smoking, they want to know, what can I do to improve my health so that it won't come back? That's kind of the underlying question, and why it's so disturbing for people to not have any risk factors but still have bladder cancer. And talking to our urologist partners in France, one of the things that came up and that is often recommended by urologists is to drink a lot of water. I mean, within the recommended limits, of course, not too much, because that's not good either, but it's something that patients can do. And you can tell them, make sure you're drinking your water every day. And to monitor.
I see conflicting.
it's curious, but there is no evidence on this. Drinking water does not decrease recurrence in bladder cancer. As far as I know, maybe there is one paper or two papers written about this. There always, you go back in PubMed and you always find a paper that someone who had a look at it. I will look for it, okay? But
well,
as
make
far
your
as I
skin
know,
nicer.
so continuously drinking more water will not decrease the harm that already has been done in the bladder cells, cancer and bladder cells. So I would say this is not, in the stones is good, in the post-op of any surgery is good, in an infection is good, but I mean, as far as I know, in order to decrease recurrence in bladder cancer, or the progression of bladder cancer, or to have a better health for your bladder, that you have bladder cancer, as far as I know, there is nothing published to drink a little of water, they will improve it.
Yes, but it's a very important point, because that's something that patients always ask. What can I do to lower my risk of recurrence? And the truth is that in bladder cancer, we don't have information about something that can, besides stop smoke and not being exposed to smoke or another toxic, environmental toxic, but beyond that, we don't have any information about food or fluid intake or sports. Or we always say, okay, you should have a healthy life. But that's common sense, you know, but we don't have any specific recommendation for patients that are going through bladder cancer to have a better prognosis.
Thank you. I want to thank everyone for joining us today for a discussion on patient support needs and the importance of collaboration in healthcare. I want to thank the panelists for your invaluable insights and contributions. And thank you, everyone.